Thank you, Kamaldeep bhai. And thank you for the invitation for this RSADI annual conference. And I'm going to talk on a bit older molecule, and that is glyclazide. As Dr. Pratap Jethwani, my previous speaker, has described very nicely that SGLT2 has changed the scenario of treating diabetes by proving CV superiority and renal safety. But at the same time, we are also having very important part of diabetes management, and that is glycemic control, where for years together since 1942, from the discovery of SU in laboratory to launching of first sulfonylurea in 1956 to even today, I will say whatever SGLT2 come, whatever DPP4 inhibitor we use, insulin is one we will always in need, and SU is something which will always in need. And when we are talking about glycemic control and various molecules, reduction in fasting and post-lunch sugar and overall HbA1c reduction, reduction in sugar, but on the other side risking patient for hypoglycemia. Guideline recommendation, protection from complications and cost of therapy also plays a role. And where we have very vast and long experience with sulfonylurea, I am going to speak specifically on glyclazide because SU, there are a number of SU, and Dr. Jethwani told that there was an era where we were worried about increased cardiovascular event because of stronger, older sulfonylurea like tolbutamide or previous generation, or I will say first generation SU. But then came second generation SU, and then came third generation SU, that is glimepiride and sustained release form of glyclazide. So let's first talk about efficacy of this molecule, where fasting sugar reduction with 60, 90, 120 milligram of glyclazide, you may have 66 to 106 milligram per deciliter reduction, and just 15 days in combination with metformin, also it reduces 50 to 87 milligram per deciliter. And that's why sulfonylurea is one of such drug which is considered as high efficacy molecule. Metformin, sulfonylurea, and I will say this GLP-1. These three molecules are considered as high efficacious molecule. Even SGLT2 comes into moderately efficacious because you can see most of other molecule have glycemic reduction capacity of 0.5 to 0.9. When we are talking about four pillars, glycemic control always plays a first role, but along with that, like SGLT2 and all other newer molecule, blood pressure management, lipid management, and risk reduction of cardiovascular renal risk is important. So let's see how this glycemic effect of modern SU is linked to unique mechanism. That now the third generation SU are considered as CV safe because they have unique mechanism that they have action on reversible attachment to a pancreatic beta cell only and not the cardiac cell, which is increasing this preconditioning. If we go to EMR based glyclazide Indian real world evidence, where glyclazide or glyclazide metformin was studied or glyclazide was compared to sitagliptin, we have data for 9 years, and this suggests that when glyclazide given alone or glyclazide metformin or glyclazide metformin as an add-on was given to some another drug, HbA1c reduction you can see more than 1% is evident, and number of patients who are achieving HbA1c of 6.5 who are previously on higher side is significant. And these are the data suggest that 51% of the patient more likely to achieve target of HbA1c of less than 6.5. So if you are using moderately efficacious drug, but at the same time renal and cardiovascular safety, if you have put patient on SGLT2, but still you need a glycemic control to be better, you may need such type of therapy. Along with that, these are the data of glyclazide comparing to gliptin as well as glimepiride as well as metformin, where glyclazide was found to be one of the strongest of all, but it may vary because sometimes practically glimepiride and gliclazide sustained release you may have to vary it, but this all are showing same result that HbA1c of 1% or more is expected. And when you compare gliclazide 30 milligram to 60 milligram, 90 milligram and 120 milligram, almost 1.78% of decrease in HbA1c is expected. And if HbA1c entry level is high like 9 or 10, you may expect more than 2% of reduction. And there is one guide study which has shown glimepiride and gliclazide efficacy. It was quite similar. So one is more stronger and one is less stronger. No, it is almost same. Many a times we feel in clinical practice that glimepiride is stronger because we are using less dose of gliclazide and we are using full dose of glimepiride. So you have to have a proper dose to dose comparison, then only you will have a similar glycemic effect. And with similar glycemic effect, if you consider hypoglycemia risk with this modern SU, even the same guide study where gliclazide and glimepiride was also studied, gliclazide has shown almost 50% lesser hypoglycemia risk when as a monotherapy was given, and when compared to glimepiride metformin combination, gliclazide metformin combination has almost 70% less hypoglycemia event. So this is very important that this is one SU which is as effective as other SU, but hypoglycemia risk is less. And to assess this risk of hypoglycemia in person with diabetes who are on SU, we have our own study from Gujarat by Dr. Bansi Sabu, Dr. Komodini and Dr. Jyotidev, where there was no extra burden of hypoglycemia was observed. You can say there was, no hypoglycemia was present in 74% of the patient. Depend on the CGM data, not on SMBG level, not on patient symptom. CGM data, 74% were not experiencing hypoglycemia and only 26% experienced grade 1 hypoglycemia with less than 5% time below range. And 2% had hypoglycemia and TBR more than 5%, which suggests that we are talking about hypoglycemia, but it is not that common, especially when HbA1c is between 7 to 8. If you are targeting very strong and tight control like HbA1c of 6.1, things may be different, but most of our patients fall into 7 to 9% of the HbA1c. Advanced study. Advanced study is one of the oldest study like ACCORD and VADT, where we are quoting that micro and macrovascular benefit with intensive control. You can see this one study where gliclazide was used, that is advanced study, where it maintained glycemic control over the period of 5 years, and 21% in intensive arm were having HbA1c of less than 6. 64% were having HbA1c of less than 6.5 and 81% were having HbA1c of less than 7. So what we are talking about, the over the period of time glycemic efficacy of SU reduces? No, we have 5 years data with us. So it is not like that SU fails after 1 or 2 years if you are controlling in a better way. So intensive early control is more important for efficacy and durability rather than a molecule. And we have another study done in patients who are observing Ramadan, where gliclazide was having hypoglycemia risk as less as sitagliptin in comparison to glimepiride and glibenclamide. Glibenclamide we all know, one of the old stronger molecule causing more hypoglycemia, and nowadays we hardly use this, so just take it out. But in comparison to glimepiride, gliclazide was having lesser hypoglycemia risk and the proportion of patient was even lesser than sitagliptin. So this is one of the very safe SU when patient is having hypoglycemia risk or when patient is observing fasting like Ramadan. So this suggests that patient who are put on gliclazide during Ramadan, it was also found to be quite safe, especially when gliclazide was given at evening time after iftari dinner and not in the morning time. Weight gain, another problem that we are talking about weight gain with sulfonylurea. Yes, patient do gain, but that is because of metabolic control, that is because of the reduction in glucotoxicity. The same thing you will observe with insulin also. So I don't think so weight gain is a very significant problem when you are thinking of using sulfonylurea, and especially with modern sulfonylurea weight gain is much lesser. Another evidence from the same advanced study in VADT Accord intensive control group where insulin or glimepiride was also given, weight gain was more. In advanced study there was no significant weight gain was observed. Actually patient, despite of better and intensive control, maintain similar weight. When we are talking about hypoglycemia, when we are talking about weight gain issue, there are another two parameters that we need to talk today, and that is CV outcome and renal outcome. Yes, we don't have as such dedicated CV outcome or renal outcome study because no company is going to do and spend million and billion dollar on this older molecule when they are not going to gain. But one, that this pancreatic SUR specificity is reducing that ischemic preconditioning, which leads to better cardiovascular safety profile. But at the same time, if you look again to this advanced trial where you can see the ACVD risk reduction was evident, and glyclazide is having lowest cardiovascular risk in comparison to all other SU, including glimepiride. Glimepiride is also quite safe in comparison to glibenclamide, glipizide, tolbutamide or ripaglinide, but glyclazide is safest of all SU when we are talking about cardiovascular safety. And when we are talking about CV related mortality risk, it is also, you can see glimepiride and glyclazide is falling on the favorable side in comparison to all other previous sulfonylurea, and glyclazide is having even better profile. Along with cardiovascular risk, even stroke risk is also not increased with glyclazide, and that's why it is making cardio as well as cerebrovascular safe molecule. It also found to be safe for myocardial infarction as well as overall 3-point MACE, and you can see the advanced study where major macro or microvascular event was reduced by 10%. Yes, you will not get 20%, 18% and 30% risk reduction like what we are getting SGLT2, but still this study suggests that these are not a bad molecule. These are also molecule which improves lifespan as well as it reduces complication of a diabetic patient. And so as for glimepiride also we have Carolina study where CV safety is proven against linagliptin. DPP4 CV safe and glimepiride is as safe as linagliptin, and if you compare glyclazide to glimepiride, even glyclazide is better molecule, then why we are afraid and why we are talking about CV risk when we are talking about SU, when we have a very good modern SU available with us. These are the data of cardiovascular safety in type 2 diabetes with as a second line drug when SU was used, where second line usage of SU is also not causing any problem. Similarly, for renal outcome, in advanced study, same, there is one subset of analysis which suggests there is 21% reduction in nephropathy, that is new macroalbuminuria or worsening of nephropathy, and the doubling of creatinine ratio in this one particular study suggests that in comparison to glimepiride, it is better. In advanced study, 65% reduction in risk of ESRD and 20% reversal to normal albuminuria was also observed. Obviously, these are not the dedicated renal study, but this also suggests that if you use molecule wisely and if you have a good intensive control, actually with such type of molecule also you can observe better result, as good as 46% reduction in ESRD which was observed. And more importantly, whatever stage of EGFR, patient is between 45 to 90 or 30 to 45 or less than 30, you can use one SU safely, and that is glyclazide. Glimepiride, if patient is renally compromised, there is a possibility of more hypoglycemia than any other longer acting molecule, but not in the case of glyclazide. And that's why the the newer SU is not considered now as a hazard to diabetes, and it's a very good and important add-on, especially for overall better glycemic control. So just my key point today is vast majority of the patient do not have established or highest CVD risk but very high sugar. They need a stronger molecule where we have a efficacious molecule in form of SU. Early and sustained control of blood glucose level prevents complication. We have data from this advanced study where glyclazide sustained release was used, and it has found early and sustained control with the best of class efficacy. With this, I would like to end my session. Thank you.